class today. My name is Neyidu Agada Godwin and I'm your regular anchor. I want to welcome you to this image artifact series, and this is our second lecture. Before we continue, I want to appreciate these wonderful people who have contributed greatly to my knowledge. Now we're going to look at all the various artifacts that we mentioned in the first episode. We're going to look at them in-depthly, one after the other. So follow me, let's get the job done. We'll start with acoustic enhancement, or what you call through transmission. Acoustic enhancement is an increase in the brightness or amplitude of the echo deep to a structure. It usually occurs whenever sound beam passes through a low or weakly attenuating structure, and this is usually characteristics of cysts. However, it is actually a misnomer. It is produced by different mechanism that is called signal processing. Hence, it is also called signal processing artifact. The cystic fluid causes almost no attenuation of the sound. So adjacent to the cyst, the liver parenchyma, for example, does cause some attenuation, and this is compensated for by TGC, which makes the liver echoes uniform from superficial to the deep aspect of the deep side of the liver. The TGC overcompensates through the cyst, hence causing the deeper echoes to appear brighter. Now, the value of these artifacts is that it greatly increases the confidence in the diagnosis of cysts or any cystic structure. Sometimes a cyst is too small for the enhancement to be explained only by the absence of attenuation. In fact, the small cysts can act as a lens, refocusing the sound beam that is similar to using a magnifying glass to focus sound ray to burn a hole in a dead leaf. So basically that's what smaller cysts will do to sound. In such cases, usually there will be no acoustic enhancement, but it refocuses. So this refocusing of the sound beam also causes enhancement through transmission. The other artifact is the refractive or refraction artifacts. And refraction artifacts is the bending of sound beam at an oblique interface between tissues of different acoustic velocities. There are different types of refractive artifacts. There is one type of refractive artifact that has appearance of a refractive shadow caused by defocusing of sound beam at the edge of a cystic structure, and this is also known as the edge effect. The other type involves displacement of distal structure by more proximal refraction of beam, and this is called split image or refractive duplication artifact. Now let's look at edge effect or edge shadowing. This is a type of refraction or refractive artifact that appears as relative acoustic shadowing owing to refraction, that is deflecting the whole sound beam to the interface that is deep to the edge of a curved structure. For example, a cyst, gallbladder, and fetal skull. The edge effect is created by two types of interactions. The first one is the refraction. Now, when a sound beam passes through a higher velocity to a lower velocity structure and strikes the edge of the curved structure at an oblique incidents. For example, liver and gallbladder bile, refraction will occur that causes the beam to bend away from the central beam axis, and the edges of the structure, that is the gallbladder, will not get, the edges will not have echo refracting back because the sound has been bent away. So reflection back towards the sound beam in the direction it came will not be possible. So since sound energy is lost along the central beam axis, a shadow is produced along the central beam axis at the edge of the gallbladder. Reason why you see those dark shadows, they are not because of bone or calcification, but usually because of refraction. And the other type that occurs is the total internal reflection, when the sound beam passes through a lower velocity to a higher velocity structure and strikes at the edge of the curved structure obliquely at a critical angle of 22 degrees or more. For example, you have amniotic fluid as against the fetal head. Total internal reflection will occur and produce edge shadowing at the edges of the curved structure, that's the fetal head. So you see that it's really not because of the bone, the skull. It's actually because of the total internal reflection that occurs. So you see that shadow at the edges. So the effect is defocusing. A defocused beam has less intense sound, less intense returning echoes, and therefore a relative shadow. The refractive shadowing can also cause confusion if it is more diffuse and only relatively attenuating. This frequently occurs through the lower uterine segment owing to the oblique interface of the superior aspect of the bladder. Now, in liver, the fissure for the ligamentum venosum may contain some fat, and the oblique interface can cause relative shadowing of the caudate lobe that is similar to metastasis. Portion of the pancreas can appear echopoor owing to interposed fat that is deep to the left lobe of the liver. And a relatively uncommon but interesting artifact is the two-tone testis artifact caused by a refraction of the testicular artery. Now, what about refractive duplication artifacts or split image artifacts? Now, in this case, the sound beam is refracted by a more proximal interface. For example, for the image of the small superior mesenteric artery, it may be duplicated when the transducer is held in a transverse plane over the midline. Now, when the beam is pointed to the right, the sound may be refracted backwards, back towards the midline by the oblique interface between the posterior aspect of the rectus abdominis and the triangular fat part behind it. Now, this causes the superior mesenteric artery image to be shifted towards the right. Now, when the sound beam is pointed to the left, it is also refracted back towards the midline and therefore displays another image of the superior mesenteric artery that is shifted towards the left. If the transducer is moved to one side or the other, the artificial duplication can be eliminated. So this type of duplication artifact may also appear causing double aorta in the abdomen. In the pelvis, it's causing a single early gestational sac to appear as twin sac, and a copper 7 IUD intrauterine device in the uterus can also appear duplicated. We call this copper 14 artifact. Now, in velocity artifact, or what you call propagation speed artifact, or speed of sound error, it is a type of misregistration error. Ultrasound machine assume that the sound speed in all soft tissue is constant at about 1,540 meter per second. Now, this is the calibration speed that is used in the ultrasound system to calculate the distance to any interface or reflector. Now, the range equation works well and accurately positions most of the echo in the display, but sound velocity in pathological or organic tissues can vary when an error containing tissue with different velocity is scanned. So incorrect depth assignment or position are seen to the tissue with lower velocity or higher velocity, and the speed error or velocity artifact begin to occur. Now, if the velocity in the tissue is slower than the soft tissue, remember the velocity of sound in soft tissue is 1.54 millimeter per microsecond. So if it's less than that, then all the go-return times will be longer than they should be, and the result will be that the echo will display farther from the transducer than they should be displayed. Fat and fluid filled structures are typical cause of these artifacts. But similarly, if the velocity in the medium is faster than the soft tissue, in other words, is greater than 1.54 millimeter microsecond, all the go return time will be shorter than they should be, with the result being that the echo will be displayed closer to the transducer than they should be. In this case, metal has a higher speed of sound. Now, the most common cause for velocity artifact is fat mass, like lipoma. The speed of fat, the speed of sound in fat is 1.44 millimeter microsecond, which is approximately 6% slower than the speed of sound in soft tissue. So sound traveling through a fatty mass will take 6% longer time to return to the transducer than the normal tissue. That's to say, echoes returning from the interface that is deep to the fat mass will be mispositioned 6% farther away from the transducer than they should be. This can simulate a break in the structure that is located posterior to the fatty lesion, such as you have the diaphragm or the capsule of kidney, and will be shown further apart than its real location. So you will not have a uniform borderline. It breaks at a certain point because of that lipoma ahead of it. So you need to remember the effect of a change in propagation speed is on the go return time. So slower to farther and farther to closer. So if you have a slower speed of sound, you have a farther image registration, and if you have a faster speed of sound, you have a closer image registration. Now, in range ambiguity artifacts, the go return time clock is reset each time a pulse is transmitted, and all echoes are assumed to be generated by the last transmitted pulse. But if a second pulse is transmitted before all the echoes returned, then the clock would be reset, and the later returning echoes will have that erroneous short go return time, since their go return time will be measured from the transmission of the second pulse. So as a result, the range equation will mislocate or misregister all the echoes closer to the transducer than they should be, and this is termed range ambiguity artifact. For example, If the depth of field was set at 2 centimeters, then the system would wait at least 26 microseconds before the pulses. That's to say, 2 centimeters times 13 microseconds per centimeter. Remember, that's the machine setting. So this would ensure that all the echoes from the maximum imaging depths have returned before any subsequent pulses are transmitted. That is, the depth of the field limits the minimum PRP, the time between the start of one pulse and the start of another next pulse, and thus it will set the maximum PRF also, which is pulse repetitive frequency. In this way, range ambiguity will be avoided. The simple calculation used to set the limit for maximum PRF is PRF maximum is equal to speed of sound divided by 2 distance, 2 times d, where d is the depth of the field and c is the speed of sound. So from this we can say that the maximum PRF is inversely proportional to the depth of field. So to avoid range ambiguity artifact, an increase in the depth of field will also necessitate decrease in the maximum PRF. Beam width artifacts. This is one of the most common artifacts seen in clinical practice. It is the fill-in artifact that is caused by beam width. In this artifact, low-level echoes are added to cystic structures. If the beam width is wide, when imaging a cystic structure, the edge of the beam may lie outside the cystic structure and within the surrounding soft tissue. This results in echoes from the edge of the beam returning to the transducer, since the system always assumes that all echoes are returning from along the central beam axis. It writes these echoes along the beam axis where they are displayed within the cyst. The result is low-level echo being seen within the cystic structure, which typically this low-level echo is seen at the edge of a cystic structure, mimicking sludge within the cyst, called pseudo-sludge. And pseudo-sludge in the normal gallbladder is a common example of fill-in echoes or beam artifacts, beam width artifacts. Other simple cystic structures which should appear echo-free may also be filled with low-level echoes due to beam width artifacts. Now, small cysts may even be completely filled with beam width artifacts, and it is usually easy to distinguish these artifacts from real echoes in real time. Now, repositioning the transducer and refocusing will often help remove these artifacts. So adjusting the focal zone and placing the object of interest within the center of the focal zone will eliminate the misplaced echo on the display. Now, in slice thickness artifact, the beam width perpendicular to the direction of scan is known as slice thickness. Slice thickness also produces low-level echoes or fill-in artifact that is identical to the beam width artifact. This only differs. The only difference here is that the slice thickness echo comes from tissue lying perpendicular to the beam axis, while the echoes from the beam width artifact arise from tissue lying along the beam axis. But both looks identical and can be minimized in a similar fashion. Its occurrence can be diminished using a correct transmit focal zone, making the slice as thin as possible. It is also called section thickness artifact or volume averaging. We assume the ultrasound beam is razor thin, yeah? That's the assumption, but in fact, it has a measurable thickness. So any echo generated from the beam edge will be displaced as though they have arisen from the center. So this is most apparent when most beam travel through fluid, but part of the beam interacts with the adjacent soft tissue. Echoes from this interface will be displayed as having arisen from inside the lumen. Here, the beam slice thickness is wider than the cystic structure that is in gallbladder or the urinary bladder, and this will cause some echoes from the soft tissue that is adjacent to the cystic structure. Soft tissue like liver, if you look at it against the gallbladder, the echoes from that soft tissue, it will cause it to return to the transducer and be written into the cyst. This results in some low-level filling echo that is called pseudo-sludge within the cyst. The task is to differentiate between true and false lesion and debris. Now, the following are clues that can be used to decide if an artifact is present or not. Debris margin is not horizontal, rather meniscus shape. So debris, the margin of debris is usually meniscus. Yeah? How do I do my hand now? Okay. Meniscus. Yeah? It's not horizontal. The margin, number two, the margin inclination is independent on the patient position. Number three, margin inclination is dependent on angulation of the transducer beam. Number four, similar debris-like echoes on non-dependent surface of the mass. Number five, height of the margin changes with overall receiver gain. Now, slice thickness artifacts can be minimized by 1. Scanning the structure using a narrow bandwidth. Number 2, decreasing the overall gain. And number 3, by placing the focal zone in the correct position. Now, signal amplification artifacts, what you call ballooning effect. This signal can be amplified stronger than the normal when very large acoustic mismatch is present between two interfaces. For example, the gallbladder surrounded by fluid as in ascites, or due to congestion in CCF, or inflammatory swelling in hepatitis. The echoes from the gallbladder or the gallbladder wall are amplified, making the gallbladder wall appear artifactually thickened. It can be somewhat controlled by gain adjustment, but it cannot be eliminated. So transducer, let's look at transducer resolution. SRARLR point spreading effect vis-a-vis focal banding. Now, spatial resolution. Poor spatial resolution is an artifact. Since a failure to the resolve adjacent interface means a loss of detail, and two closely spaced interfaces are displaced as one echo rather than two. Axial resolution is dependent on spatial pulse length, which is directly dependent on transducer frequency. A good clinical example of the impact of satisfactory and unsatisfactory axial resolution is the display of normal pancreatic duct. With adequate axial resolution, the pancreatic duct can be visualized in the body of the pancreas as a tubular structure with two parallel echogenic wall and an anechoic lumen. With unsatisfactory axial resolution, the duct is either not visualized or seen as a single echogenic line. In lateral resolution is equal to the beam width. The wider the beam, the poorer the lateral resolution. So two laterally placed artifacts that may have been resolved as two interfaces in the focal zone may not be resolved as separate interfaces in a wider part of the beam. Point spreading effect here, it is another artifact that is caused by beam width. Point spreading causes a small point interface to be displayed as a short horizontal line. The wider the beam, the longer the line appears. The width of the echo is equal to the beam width at any given depth and shows beam profile. And usually you see that in low, personally I've seen that in low-end scanning machines. That's the focal zone banding. Here is the focal zone banding is a display of increased echo brightness in a narrow zone that is related to increased intensity of focal region of the beam. This phenomenon is commonly seen in liver, since the structure is large and encompasses both the near and far field of sound beam. Focal banding can be reduced or avoided by proper setting of the TGC by the sonologist. Now, electronic noise is usually due to extrinsic electrical interference that is being received by the system with consequent amplification and artifacts on the display. It is usually worse at high gain setting. Noise may be displayed as a low amplitude echo that are added to the display. Like many other artifacts, these echoes are typically only seen in what otherwise would have been an anechoic structure. These noisy or low-level echoes do not tend to change with a change in transducer position or patient position, so can be distinguished from the real interface. Noise can be minimized by decreasing the overall gain. However, correction may be required, moving the system away from the source of interference. And we have equipment malfunction. Speckle is the artifactual dot pattern that is displayed from tissue. It is considered a form of noise and generally produces a very fine dot pattern in near field, which becomes coarse in the far field because the attenuation filters out the higher frequency echoes. This is an inherent sonographic artifact which cannot be corrected by the sonologist. Manufacturers continues to work to reduce speckle, but again, it's a work in progress, and you just know how to identify them and avoid them in your diagnosis. So equipment malfunctions may cause various types of unusual artifacts, such as deformed or broken elements, broken transducer damping, defective multi-format camera, film processing artifacts, and so on. Artifacts that are associated with spectral and color flow. We have the ghosting or flash artifacts, range ambiguity, or what you call misregistration. We have clutter, color twinkle artifact, slice thickness, reverberation, incident beam, angle, and so on and so forth. Now, aliasing can occur with both pulse Doppler and color Doppler. It occurs when the Doppler shift exceeds the Nyquist limit, which is equal to half of the PRF. The Doppler shift that exceeds the Nyquist limit is falsely displayed on the opposite channel. In power Doppler, this shift is seen on the opposite side of the baseline, creating a new baseline. aliasing in color Doppler displays all shifts that exceed the Nyquist limit in lighter color from the opposite channel. Thus, the higher the shift from one channel starts to be displayed with the color map from the higher shifts in the opposite channel. In color aliasing, the wraps around from the light shades at one end of the map to light shades at the other end. For example, the aliased region might be displayed with echoes of light red and shades of light blue. Aliasing can be very useful artifact because it has a distinct appearance in image. Aliasing can be used to quickly alert the observer to a region of higher than normal blood flow velocity in a stenotic vessel. To do this, the sonologist sets the PRF such that normal systolic velocity will produce Doppler shift that falls just below the Nyquist limit. Thus, if abnormally high velocities are encountered, the Doppler image will alias, drawing the attention of the sonologist to the region of increased low velocity with stenotic vessel. Aliasing can be corrected by lowering the baseline, increasing the scale or PRF, decreasing the Doppler frequency, that is transmit frequency. 4, switch the system to continuous wave Doppler. Now, ghosting or flash artifact. This is a color Doppler artifact related to inappropriate color processing. For example, inappropriate color display occurs over non-vascular structures such as soft tissue in the upper abdomen that move during respiration. Now, soft tissue should be displayed as grayscale echoes, not in color. So color may be written over the structure because of their movement. Decreasing the color gain below a threshold level for the display of color vis-a-vis display of grayscale pixel or adjusting the wall filter can help reduce the flash artifact. In clutter is actually similar, is a similar low amplitude, low velocity Doppler noise related to vessel wall motion or cardiac wall motion. It can be eliminated from the display with the appropriate use of wall filter control. Now, there is color twinkling artifact. The color twinkling artifact is an interesting color artifact that can be seen behind non-moving structures with color Doppler and pulse wave Doppler, or power Doppler, sorry. Using color Doppler, a comet tail of red and blue color can be seen behind strong non-mobile reflectors such as cholesterol crystals in gallbladder, especially in the gallbladder wall. Small urinary tract stones in the kidney or ureter behind the encrusted urethral stents, or small liver calcification. You can also have that in intravascular cords and so on. It is postulated that the irregular surface of these strong reflectors cause phase jitters, which the system interprets as Doppler shift. And range ambiguity in Doppler. Remember, range ambiguity we talked about before, that's misregistration error. Now in Doppler is when the exact depth of a Doppler signal, that's the velocity, is not known. This occurs with all continuous wave Doppler. Continuous wave Doppler samples all along the beam line and not specific to one particular depth, as in pulse wave. Hence, it does not give us the maximum Doppler shift. So with these insights, I want you to join us in our next series, the next episode in the series, for more artifacts and how they occur. I thank you for joining this lecture. Please let us know your opinion by commenting in the section. Like, share, and subscribe to our channel. Put on the notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp at +234 9019 144 175, or you can visit us at sonoeyes.business.site. Attempt the quizzes in the description and leave us a comment. Until the next time when I come your way again, keep learning ultrasound.